But today, a young clinician can make the difference in obtaining high levels of predictability by using a system such as DIO Navi. Very hard to top this as well. The case I'm about to show you next is a perfect case to start with guided surgery, a simple, straightforward case. This is a case that I could easily perform freehand, unless I wanted it absolutely perfect, which I did, because this was my dad. You see, my dad does not like dentists one bit, so I wanted a system that could be very reliable and, of course, minimally invasive. You can see that we have nice keratinized soft tissue, plenty of bone available, a deep vestibulum. So apparently we have no real need for soft tissue management, meaning we don't need to raise the flap. If we did, we could reposition the keratinized tissue or perform a vestibulum deepening procedure, such as vestibuloplasty or free gingival graft. So I started this case by performing a CBCT scan, where upon examination there was an abundance of hard tissue to be found. A large amount of bone means that we can't place our implants completely dictated by the final prosthesis. On a case like this, we are not in need for augmentation procedures. And also, if our implants are completely placed inside medullar bone, comprised between cortical bone and the vestibular and the lingual, this means that this surgery is going to be very predictable. Drilling against cortical bone, as we do, for instance, on post-extraction implants, can lower the predictability of the surgery because our drill tends to take the path of least resistance and slide off the dense bone. DIO Navi team has addressed this problem with the introduction of their special kit, where one can find special burrs designed to perform an osteotomy on dense steep bone. In this case, we also have teeth, so we are going to use a tooth-supported guide, which is a very precise method. Next step was to acquire an intraoral scan of both arches. This is done with an intraoral scanner, and in partially edentulous cases, it can be hard to obtain a complete mesh closure. If that is the case, or if you don't have an intraoral scanner, you can get impressions from both jaws and send them to DIO. Of course, the distortion caused by the impression procedure, the impression material contraction, the cast expansion, the bubbles on the surface, etc., is something to take into account. This is particularly true when dealing with periodontal patients or patients wearing braces. Impressions from these cases are much inferior to the results that an intraoral scanner can obtain. We then start a collaboration with DIO, where we suggest the implant placement, and then rectify, if needed, the proposed treatment by their team. Once we agree about everything, in a few days you will receive a box. Inside you will find a surgical protocol with a surgical sequence to be used, including the depth, diameter, and offset for each implant. You will also find a surgical report and a drilling protocol, that is, detailed documentation that will ensure you have all the adequate information to proceed with the surgery. Also inside are the planned implants, the guides themselves, the custom abutments, the teeth, and in the event that you don't want to load your implants immediately, the cover screws. So I'm checking the fit of this guide, as you can see by the windows on the guide, and the adaptation is just perfect. The first drill we should be using is this tissue punch. It is actually a very small tissue punch, very minimally invasive. Sometimes though, we need to remove the guide to ensure all soft tissue was removed, despite the expert being completely able to remove it as well. I don't use irrigation for this. The second bore is designed to flatten the ridge by removing bone, and I am using the first mark as a reference because it indicates the 9mm offset, which is the distance from the top of the implant, from the crest of the implant to the guide tube stop. I am using high rotation along with copious irrigation, making sure that we remove this burr quite a few times from the guide tube in order to remove the bone debris that may be present. We irrigate inside the canal between burrs every time. We then proceed with this 5mm in length burr. This is because we need to ensure contact at all times between the guide tube and the bone. It also helps to create vertical space for the subsequent burr since we are working on the posterior side of the mouth. The inner sleeve is required to use the 2mm drill. Here you can see me using it without irrigation, drilling at low speed, always irrigating between burrs. Now, for the 2.7 burr, again, we start with a shorter burr and proceed to use a longer size. We will be placing regular size implants here, and what we need to make sure is to align the prominence of the guide with the mark on the mountain. This will ensure that an internal hexagon side is facing the vestibula. We are using a 9mm fixed offset mounter, so no need to worry about depth. We are at the correct depth when the mounter stop hits the guide stop. So here we have it, a fairly simple surgery that we have replicated on the remaining implant sides. Since we are dealing with posterior teeth this time, I chose not to load this case. So no need to create space for abutments, which is achieved by using a special burr. Despite being apparently easy, case selection for your first case is of particular importance. Many times, clinicians that have limited experience with guide systems ask advice for complex cases and propose the use of a guide, hoping that the use of this technology can transform a challenging case into an approachable one. What you really should be doing is select a case like this one. Cases where teeth have mobility, unusual anatomy, post-extraction, severely resorbed ridges, etc. are probably better left to be treated with a freehand approach if your experience with guided systems is limited. If you are experiencing guided surgery, on the other hand, you will surely benefit greatly from a very precise surgery on complex cases.
Let's take a look at a case regarding precision. This is a patient with an upper denture. We decided to treat the lower part first. In 2017, I placed implants in the lower part by hand. It was general surgery. In 2019, I placed implants in the upper part with DIO Navi. I took care of the upper part with DIO Navi and the lower part with hand. Since the upper part had a denture, I only did some punching and didn't take any other measures. I just drilled it. I drilled, put the cover screw on it, and sent the patient home. There was no problem. After punching, I didn't do anything. I did final setting and gave regular checkups for 6 months. Since I had done the lower part with hand, the location wasn't good. In the case of number 46, it's too close. Number 36 is all right, but number 37 is distal. It should have been more mesial. So there was such problem. It was when we compared 2017 and 2020. Even recently, I've been placing them with my hand sometimes. Of course, most of the time I use DIO, but there are times when you do it with hands. There were some cases where the location was not as good. It's because it was pushed by hand. I've chosen a few cases related to bad positioning in the last 2 years or so. It's another case. This was a normal surgery done with hands. The patient was 83 years old. I didn't think much about it and just did the implants in line with the insurance. I took out the number 43 tooth and took panorama but no CTs. I had that surgery in 2019. It wasn't a big surgery, but this happened. I had a CT scan of the initial drill, and it was too narrow. I was tricked. Here's what happened. So I fixed the path. I did GBR. This is the CT before GBR. So, as you all know, it's especially hard to treat the mandibular anterior region with foresight. That's why you need navigation. I checked and corrected path with guide pin and confirmed final fixture position. Then, after the second surgery, there was a bone formation on the buccal side of the bone graft area. This is 4 months after the surgery. I placed the abutment and attached PFM in line with the insurance coverage. And then there's another case. This case made me think that DIO is really precise. This is a mandibular anterior region. Here's the nutrition tube. It's either a nutrition tube or a blood vessel. This case went along perfectly with the plan. It was an admirable case. I've been using DIO since 2014, and this was my first case. Look at how it's the premolar. It's in there so precisely. This is a molar area case. Look how neat it is. It's easy to use prosthesis, and this is a follow-up after 1 year and 6 months. It's another case involving the molar area. If you look closely, you'll see that I performed the maxillary sinus augmentation surgery with DIO. These cases turned out really well. This is a temporary prosthetic. It's going in as a temporary prosthetic. If you look at this is a sinus augmentation surgery. The number 13 tooth was hidden, and there was spacing, so the space is quite small. So I followed up with DIO for 4 years. It turned out pretty good. If you look here, it's in number 3. In fact, it's not possible to match them because there's no number 3. So I used DIO to place it. If you look at it from the mesial or distal view, you'll understand that placing it with hands won't be that precise. So I think that's the strength of DIO. You can say that the location of the implant is very precise. It's another case. The number 28 tooth is hidden. I could actually take out the hidden tooth. I've extracted a lot of wisdom teeth. Actually, I'm not confident about this. I think it'll be a little hard to take it out because I'll need to delete the bones a lot. So I avoided the spot to place it. I placed it with DIO and did follow-ups for 1 year and 4 months. It was maintained well. It's a case that avoided structures. This is from 2015. The bone loss was very severe, number 10, number 40, and number 30. So I waited for about 10 weeks after extraction. But placing it at the number 16 area didn't seem like a good idea because of number 17, and they didn't have a good ratio. The crown root ratio was at about 1:4. Since gagging was also severe, I divided the surgery into 3 parts and proceeded with it one by one. I placed it strategically in the back using DIO. I placed it at number 18. So I finished the surgery. I finished setting the prosthesis and made a follow-up appointment after 3 years and 4 months. The patient has had no problem so far. It's been 3 years and 4 months, and the bones regenerated a lot. But realistically, we can't wait for 3 years. So strategically, placing at number 18 can be a very good treatment option. Next is the residual dental root case. This patient had terrible pain on the lower left side. But if you look at number 35, there's internal absorption going on, and the surrounding bones are a bit weird too. I looked at the CT later, and there was a problem. I tried to extract the tooth first, but failed. I was too mindful of doing the implant later that I didn't want to touch the outer bones too much, and this left the dental roots. So I took out more than this. I removed some of them, but the patient missed the appointment 4 days later. He came back after 4 months. Then, what kind of problem can we expect? It's covered at the top. This one is from the day of the extraction. I took out more than this. This is CT from the extraction day, not 4 months later. So they were all still there. I've heard some dentists say that the residual roots could rise, but I've never seen such a thing happen. They are remaining in there, so I covered it. So what I did with the covered roots is that I made a plan with DIO. I ground the root area and placed the implants. I got rid of those in the surgery. This is a panorama from the day of surgery. I followed up after 6 months since the surgery. I followed up after 19 months. It looked a bit weird, so I asked a friend from Panorama's radiology department about it, and he said there was no problem. So I'm using it. The bone pattern was weird. But if you look at it, it hasn't changed much. It's after 19 months of follow-up. If you look closely at the existing prosthesis, it was a cantilever. So in this case, it was ambiguous to use a cantilever, and the back teeth were lying down a lot, so I purposely raised the contact. That's a good option. This is better for your teeth. So I opened the contact and made the back teeth usable. Let's look at a case involving nerves. This patient came in 2018, and it was a difficult case. You'll see later on CT, but if you look closely, there's no bone in number 10. The lower jaw looks like it has much bone, but there isn't much to use actually. It had a lot of useless bones on the lingual side. I did GBR as soon as I took out number 40. Then I planned. But I made a mistake. If you look closely, it looks like there are a lot of lateral bones, but in reality, there wasn't much bone I could use. It was close to the nerves too. I've got the GBR spot right here. There was a good bone in the back, but I didn't place it there. I placed it in this spot to reduce the force to the front from the prosthetic. But the location wasn't good. In fact, you don't place it in a spot like that. So I failed. Actually, it wasn't a failure, but I took it out. It wasn't even fixed. Of course, it wasn't fixed since not much time had passed after GBR. So I decided to take this out and have another surgery. It's a lot farther back than where it was before. The patient agreed to place it in the back, so we set up an appointment 1 week later. So I worked on the relocation. It was over in 7 minutes. That's the good thing about stent surgery. I was worried that the patient might say something else. As you can see, it's really close to the nerve. It was really close. Still, I believed in DIO and went ahead with drilling. So it was over in 7 minutes. Look at how it is first placed. It's very close to the nerve. The second one is also close. But I placed it neatly without any problems. 4 months later, I put up the prosthesis. Zirconia went into number 40 and PFM into number 10, although at the time, temporary prosthesis was placed. This is 8 months after surgery. This is 19 months after surgery. If you look at the bottom left, I finally took it out. I took it out and placed it with DIO. As you can see, the bones treated with GBR has dissolved a lot, but there hasn't been any problem. And this is my second case that was close to the nerves. If you look at number 30, there isn't much bone left. So when I looked at it 2 or 3 months after the extraction, it was very close to the nerve. The cortical bone almost became a woven bone, and there's little lamellar bone left. The CT is hard to read, so I had to place it deeper. Unless the boundaries are clear. The shortest implant in DIO is 7 millimeters. I wanted to place it deeper, but because of the safety zone, it didn't allow me to design it like that. It should have been 2 millimeters. You have to put more in, but you can't design it, and if you put in 7 millimeters, it's a little shallow. So what do I do? Because of its proximity to alveolar nerve, my heart was pounding. So I took a scan in the middle of surgery, and I placed a 6 millimeter one from another company, so I could put it in more. I tried to place it as low as possible. Thanks to DIO, I didn't damage the nerve at all. so the placement was successful and there hasn't been any problem.